Bui, a second-year resident from Cedars Sinai Medical Center in California. Today I would like to show you a case. A 55-year-old female presented with postmenopausal bleeding and pelvic pain. She had an endometrial biopsy, and here we can see a hypercellular lesion. At higher bowel, we see two components, a solid growth of spindle cells and tubular or papillary pattern of epithelial cells with hyalinite material resembling Sescott architecture. On higher bowel, we can appreciate the cytology. The cells have variable vesicular nuclei and inconspicuous nuclei. Based on the morphology, we came up with these differential diagnoses. There are 5 entities that can have Sescott-like differentiation, including endometrial stromal tumor, endometrial carcinoma, adenosarcoma, uterine tumor resembling ovarian Sescott tumor or uterus, and mesonephric adenocarcinoma. To be able to find out the diagnosis, we order immunostains. Here are SF1 and inhibin Sescott markers, and they were negative in the tumor. WT1 was diffusely positive. Carotene were more strongly positive in the epithelial component than the spindle cell component. A1, A3, and CK7 were positive in the epithelial component with the same pattern. Because the tumor expressed cytokeratin, carotene, and WT1, it raised the concern about mesothelioma. Although the location is not typical for mesothelioma, we still order more mesothelial markers, including CK56, D240, and they were all negative, so we excluded mesothelioma. EMA and PAX-A were done, and they were negative in tumors, so we could rule out endometrial carcinoma with Sescott-like differentiation. Since the tumor was also positive for ER and PR, we could exclude mesonephric adenocarcinoma as well. The tumor also expressed Deadmin, P16, and CD10. This is a summary of the immunostain. FOXL2 and NGS sarcoma panel were ordered, and they were sent out because we don't have in-house. We already excluded endometrial carcinoma and mesonephric adenocarcinoma, so the remaining differential diagnoses include endometrial stromal tumor, adenosarcoma, and uterine tumor resembling ovarian Sescott tumor or uterus. The biopsy was side out as Mullerian mesenchymal neoplasm with 3 differential diagnoses that I just showed you. Subsequently, we got result of FOXL2 immunostain. FOXL2 is not only an immunomarker for granular cell tumor but also for Sescott elements. FOXL2 were positive in spindle cell component. NGS sarcoma panel showed that all gene fusions were negative. I just want to highlight that the tumor lacks ZAPF1, which is commonly seen in low-grade endometrial stromal sarcoma, and the tumor was also bad negative for NCON2, which is found in use drug. NCOA1 and 3 that can be found in use drug wasn't performed because they are not available for commercial use yet. Subsequently, the patient has a CT scan of the pelvis. CT showed an enhancing mass centrally within the uterus extending into the endocervix. After reviewing the biopsy and CT scan, the GYN team decided to do a hysterectomy. We can see the tumor is located on the left side of the uterine corpus, measuring 5 cm in the greatest dimension. The tumor is polypoid yellowish and doesn't involve the cervix. In the cross-section, we can see that the tumor entered the myometrium but does not involve the serosa. This is a representative section of the resection. We can see hypercellular lesion involve the endometrium and myometrium. The tumor enters the myometrium to a depth of 1.7 cm out of a wall thickness of 2.2 cm. In this photo, we can see nests of clear cells or lepidite cells, which we didn't see in the biopsy. And the radical architecture is better seen here than the biopsy as well. We also see spindle cell and epithelial cell components similar to the biopsy. In summary, the whole tumor is composed of the different separate elements. SF1 was positive in clear cells and subsets of spindle cells. Inhibin was positive in clear cells as well. We did an additional second marker melanase were negative. Muscle markers only desmin were positive. Other muscle markers like caldesmon, myogenin, and myod1 were negative. In summary, SF1 and inhibin were negative in the biopsy, but positive in the resection. This could be because the resection contains clear cell components that weren't captured by the biopsy. These were the areas that stand positive for SF1 and inhibin. These findings show that it can be challenging to diagnose the entities on biopsy specimens when we don't see the whole lesions. Besides SF1 and inhibin, other immunomarkers were compatible between the biopsy and the resection. The tumor expressed some sesquark epithelial and muscle markers and was also positive for CD10, ER, and PR. The immunopanel is compatible with UTROS. Karyotype was performed and it showed a complex abnormal clone in a limited study of 5 cells, so this study wasn't helpful. The case was cited out as UTROS or uterine tumor resembling ovarian sarcoma tumor based on the morphology and immunostain panel. Thank you for listening to my case. I hope you enjoy it.